So we're going to learn some diagnostic and management tools for very common disorders of the stomach and small bowel. Last year when or 2 years ago now, when I gave this lecture, I think I just put too much in here, and it's still probably going to be a little too much, but I'll try to go through it a little more systematically. I did take out a few things, so hopefully it'll be a little shorter. And hopefully we can learn to identify and manage some of the emergencies that we see in the stomach and small bowel. Again, one of the goals in medicine is to be able to determine sometimes the not so sick people from the really sick people. And it's very difficult in some situations to know what's a true emergency, particularly when it comes to the bowels. So hopefully we'll go through some of those nuances with you guys today. Okay, next slide. All right, so where can you learn more about GI diseases? Now, the places that I recommend that you go, I put up to date sort of last, although I think as residents, that's usually the first place we go to, but sometimes it's not as current as you might imagine. So if you had to turn to books, I would say the best book that probably explains the pathophysiology of various GI diseases is the Schlesinger and Fortran's GI and liver disease book, which is available through the DML library, and it's free. So if you're ever wanting to read, okay, why does this disease happen? What population? What is the pathophysiology? That should be your go-to book. But I often will rely on more reviews and journal articles as my first go-to to learn about a new disease. And the ones that I've, as a fellow and as a resident, I use very often were the New England Journal reviews, as well as the JAMA Network reviews. And I think those were super helpful because they are more up-to-date than up-to-date. But of course, in a pinch, if you really just needed to get to something and up-to-date is always fast and easy. Now, when you become a fellow in GI, we really do require that you follow more the patient guidance the guidelines and from our national societies so that you're really up-to-date. And that comes from the American Gastroenterological Association, the ASLD, ACG, and ASGE. So we often will turn to those websites and look up the guidelines to see exactly what the most current management is. So some of the talk today is really giving you that information from these guidelines. So in general, these are the disorders we're going to talk about today. I did take out cancers of the GI tract from here because I think that should probably be covered in oncology. And we're just going to talk about a few things that are very common. And I'm going to teach you a few things that maybe not as common, but you should know about because they show up on a lot of boards and things like that. And then the emergencies, which I think you should always be aware of when you're seeing that in patients. Okay. So of all the disorders of the stomach, now this is a sort of a generic list, but you can break them up into common, less common, and then the emergencies. The most common is peptic ulcer disease, right? And so we're going to talk pretty much about that and make sure that you guys understand what is the pathophysiology of this disease and what's the appropriate management of it. We'll talk a little bit about eosinophilic gastritis and Minotaurs disease, and these are just diseases that are not as common, but they show up a lot on boards for whatever reason. And so it's important for you to know that. And then the emergency. So let's talk about peptic ulcer disease. So very, very common disease in the population, but has various causes, right? And the most common of those is probably infection with Helicobacter pylori. But the next most common is likely NSAID gastropathy. And what happens there? Well, NSAIDs tend to block the COX-1 enzyme, and that decreases the production of prostaglandins in the gut, and that impairs appropriate bicarb secretion, and the lack of that mucus layer that contains the bicarb leads to basically ineffective acid suppression. And so you have acid that's coming in contact with gastric mucosa that eventually leads to erosion of the mucosa lining. Eventually that becomes, initially it's sort of superficial and we call that an erosion, but when it's really gotten past the lamina propria, that's when it's really become an ulcer, and we call it peptic ulcer disease. Okay, so there is a distinction, and many of you might have seen endoscopic reports from several of us gastroenterologists saying, oh, this is just an erosion and, we're just going to treat it and you don't need to come back for a repeat EGD. And other people have an ulcer and we ask that they do come back for an EGD. And why is that? And I'll go into that in a little bit more detail in a few minutes, okay? Other causes, illicit substances like cocaine, methamphetamines can lead to ischemia. Bisphosphonate therapy can sometimes create kind of a chemical gastritis. just like NSAID gastropathy doesn't usually affect the COX-1 enzyme, but in other ways does decrease the bicarb secretion. Steroids, same thing. Stress, same thing. You have endogenous hormones, endogenous steroids that are getting produced there. Alcohol effectively just gets rid of the bicarb layer. And so it's another cause of gastritis. Zollinger-Ellison is one of the things that, when we see patients for endoscopy and they have numerous ulcers in their stomach and the small intestine, we often think of this disease. And this is a gastronoma, right? It occurs in the gastronoma triangle. Usually results from excess gastrin production from the gastronoma. Now, gastrin doesn't directly increase acid production. What it does is it acts on the ECL cells of the stomach to increase histamine production. And it's the histamine that acts on the parietal cells to increase their acid production. As you remember, the parietal cells are the primary acid-producing cells in the stomach. Systemic mastocytosis is a common cause as well. We're seeing a lot of this in patients with allergic type of disorders. And that, again, excess histamine secretion in that situation leads to acid production from the parietal cells. There's eosinophilic gastritis, which I'll talk about, which can also cause peptic ulcers, but we'll discuss it in further detail below. Gastric cancers can present as a first, their first presentation can be an ulcerated mass that's bleeding. So they're certainly on the differential. Certain viral infections like CMV and immunocompromised hosts can do that, as well as rare causes like Meckel's diverticulum that has heterotopic gastric mucosa in the stomach lining. So often the clinical presentation is people presenting with epigastric pain. But, one thing you should know about the viscera is that they are not good at localizing pain so much. You have a more diffuse sense of pain. It's not like on your skin. If you get a cut, it's very, you can see it, but beyond that, exactly where that cut occurred. But in the visceral organs, actually, the sensory nerves are a bit more diffuse. And so it's harder to localize exactly where the lesion is, because the pain might be felt in different parts. But typically, things that are happening in the stomach and duodenum will present as epigastric pain, but not always. And that's why I say that it can be more generalized. Often the pain is squeezing in nature. People may say stabbing, but it's really more of like a squeezing, twisting pain. That's one of the things I include in my H&P is sort of the quality of that pain. And so if they describe it as squeezing, it's more likely to be like a peptic ulcer type of situation. There can be an association with meals. So depending on where the ulcer is, some people, if it's a gastric ulcer, sometimes they'll have pain sort of immediately associated with the meal. In other cases, they'll have pain sort of if they're on an empty stomach. And it all has to do with sort of what's happening in terms of peristalsis and what is it doing to the area around the ulcer. If there's peristalsis and that's moving the ulcer and the sensory nerves around that are getting irritated, then there's going to be some association with meals during the various prandial phases of food digestion. Some people will report nocturnal symptoms as well with peptic ulcer disease, again, because they are not, they're not necessarily eating, but on an empty stomach, that's when, you can still get some degree of peristalsis and it can lead to pain at night. In some severe cases, people will have nausea and vomiting. Actually, I shouldn't say in severe cases. I've seen patients with just even very small erosions present with severe nausea. And it's funny how different people have different kind of visceral hypersensitivity to pain. And that's the phrase we use, actually, that even a small erosion can feel like a very large, what you would expect would be like a 1 centimeter ulcer, and yet it's just a tiny erosion. So you can't always say that a person who's having nausea will necessarily have a very severe lesion, although endoscopic findings have seen quite a bit of range in that. Again, GI bleeding is probably the most concerning of these findings. Anytime you hear a patient describe that they are seeing blood in their vomit or in their stool, that is something of concern, so you should pay attention to that. All right, so Helicobacter pylori is, in fact, the most common bacterial infection of humans. In certain studies, and the most recent one that was done looking at prevalence of H. pylori around the world, it was done in 2002, they found that up to 50% of the population worldwide may at some point have been affected by this bacteria. The most common risk factors for acquiring infection, at least in our country, are low socioeconomic status, having more people in your household, having an infected parent, often an infected mother, has been associated with higher risk. There is a small sort of male predominance. It's not like a 2-to-1 ratio or anything like that, but there, in various studies, they have noted that there is a slightly higher male predominance to active infection than females. And one of the studies thought that maybe this was because females get antibiotics for various reasons, but I don't know if that's necessarily a well-founded conclusion. But anyway, there is an ethnic prevalence. You do see this in patients of African Americans, Hispanic, Native Americans, and ethnic groups born outside the US. Whether or not that's associated with socioeconomic status or not, I think that remains to be noted, but often we do see patients who are born outside the US have much higher prevalence for active H. pylori in the US. Again, higher prevalence rates are noted in patients who are living close to the US-Mexico border, as much as almost 40%. Not that we need to worry about that, but we can get people who've moved from those areas, and so if they're presenting with pain and that they've moved from that Texas region, you want to make sure you're including this on your differential. So there's 3 kind of flavors of H. pylori disease. Probably the most common one is the duodenal, the simple gastritis phenotype, 85%. And there you see a mild mixed gastritis. It kind of affects almost all of the corpus of the stomach, and you get normal acid secretion. You don't see any atrophy of the gastric mucosa, and most people don't get significant clinical outcome. They might get some erosions, they might get a few ulcers, but really nothing bad happens to them if they're caught and we find that they have this and we can treat them. Really, it's a one and done situation. Now, the people who have the more serious subtypes are the duodenal ulcer phenotype and the gastric cancer phenotype. The duodenal ulcer phenotype is very interesting because that is, it's again in about 10 to 15% of people. So in this case, what happens is the organism really kind of is harbored in the antrum of the stomach, and it leads to very high acid secretion. And what it does is that the ammonia that it releases, it prevents the antral D cells from really being able to sense how much acid is there. And so because it can't sense exactly how much acid is there, it doesn't release the appropriate amount of somatostatin to suppress gastrin secretion. And so you get very high gastrin levels and therefore high HCl levels in the stomach. And that eventually goes into the duodenum, right? Because in the duodenum, you're supposed to get all your pancreatic juices coming in and neutralizing all the acid from the stomach. But because there's just so much of it going through, it's not sufficient to fully get neutralized. And so you form these duodenal ulcers. Now, in some of these patients, we do see that they have diarrhea as one of the symptoms of their H. pylori infection. So anytime someone's coming to you with kind of a dyspepsia, epigastric pain, and a little bit of diarrhea, you really do need to think about H. pylori, and don't let the diarrhea throw you off and think that, oh, it's something else, it's some lower GI problem. It can also be H. pylori, so make sure you test them for H. pylori in those instances. The gastric cancer phenotype is probably the scariest. Again, only occurs in about 1% of people, but it really leads to infection of the parietal cells, which tend to be more in the fundus and the corpus there, and it kills them. And so you actually don't produce a lot of acid, and that is what ultimately leads to more atrophic gastritis and the increased inflammation that leads to gastric cancer formation. So those folks we have to keep a very close eye on. Okay. Who is probably at higher risk for gastric cancer? It's people who've had an infection with H. pylori that had the CAG-A virulence factor. So CAG-A is a type of a secretion system. It's like a syringe. Okay, so the bacteria basically uses it to inject stuff into the host cell, and it's injecting material that can stimulate the proliferation of those cells, inhibit their apoptosis. So really what you're doing, you're changing that cell's ability to undergo normal cell cycle. And most cells, right, they're supposed to like go through these phases, G phase, S phase, and then grow up and then senesce and then die. But what this does is by injecting these proteins, you actually allow those cells to prevent the normal cell cycle progression, and they're inhibited from apoptosis so they can proliferate. They're also better at getting nutrients and being able to sequester iron. And so it's a very kind of interesting virulence factor that actually promotes, cancer formation in a lot of cells. So that was just a brief background. Who should we be thinking about testing when we have patients in our clinic? Obviously, anyone that you have heard or know has active peptic ulcer disease. So if it's a patient who was scoped for whatever other reason and were incidentally found to have an ulcer, you really should be testing and treating them if they're positive. Other than that, really anyone with any symptoms of dyspepsia, you should be testing and treating. Anyone with a past history of peptic ulcer disease that did not receive a test of cure, where they took a test after, and we'll talk about this in greater detail, but if they didn't get a test where they, after they've completed therapy that showed that it was negative, then you should test them again, and if they're positive, treat them again. People who have any kind of lymphoma that they develop or early gastric cancer, you must test these people and treat them, because if the underlying cause is the H. pylori, you have a very, very high rate of survival in these patients once the H. pylori is cured. So anyone who's on long-term low-dose aspirin, there's now a recommendation by ACG that those patients be tested or considered for testing to reduce any risk of potential ulcer bleeding over the long run. So that's another kind of new change in the guidelines since 2017. And anyone that you're considering starting on non-steroidal anti-inflammatory therapies, please test them and make sure that they don't have it before you start them on the, like 800 milligrams of diclofenac or something like that. Anyone with unexplained iron deficiency anemia should get it. And here's one that's always in tests and things like that. Anyone with ITP, a newly diagnosed ITP, should be tested for H. pylori. Why that is, we still are working that out, but really it's kind of one of those things that you should probably know for a test question. Again, anyone under age of 60 with uninvestigated dyspepsia, without alarm features, you can easily test and treat in your clinic. Anyone with alarm features, what's alarm features? Well, those are patients who have nausea, vomiting, weight loss, any kind of bleeding, okay, whether that's, melena or metachesia or anything like that. That's an alarm feature. So if they're having alarm features, please make sure you refer them to GI, because they actually need to undergo endoscopic treatment. All right, who doesn't need to be treated? Those are patients with very typical GERD symptoms. So they're having acid reflux, heartburn, and they don't have any history of peptic ulcer disease. You don't need to test and treat those folks, because again, most of it's going to be acid reflux related. You don't have to test people with a family history of gastric cancer. A personal history of gastric cancer, if they've never been tested, yes, but no one for just because they have a family history. And again, you don't need to test patients who have lymphocytic gastritis or gastric polyps or hyperemesis gravidarum. All right, so what are the tests that are suitable? So you can do, these are the three that are recommended. There are more than these, obviously, but I think for your purposes, hopefully, these are the ones that are easily accessible for all of you. I think of these, I'll tell you which one I tend to use and when and where, but you can kind of pick and choose what you prefer. So urea breath test is probably the best because it has 96% sensitivity and about 93% specificity. The way it works is the patient has to come in to do this test. They do a sample, initial sample, okay, then they drink a liquid that contains urea with some labeled carbon in it. They wait about 15 minutes, and during this time, if you have H. pylori present in your stomach, it'll break down the urea and it will release carbon dioxide gas, and that carbon was already labeled. So now you can, when they expel that gas in their breath, you can collect that sample and measure the amount of radiolabeled CO2 gas that's present. And so if it's positive above a certain certain threshold, it'll say, okay, you have H. pylori. But that requires people coming in, and obviously during COVID, we weren't doing these kinds of breath tests and avoiding them. So may not be a top pick for a lot of patients. So sometimes a stool antigen is preferred. That's about 91% sensitive, 93 sensitive and 93% specific, so a little less than breath test. And it's important, if you're doing the stool antigen, the patient not have been on any PPI or oral bismuth, like that's Pepto-Bismol or antibiotics, for about 2 weeks before, because it reduces the sensitivity and also the specificity of the test. And lastly, there's serology. These are your IgM and IgG. IgM usually, tells you about active infection, and IgG typically more latent infection. But they're not always as sensitive or as specific. And especially the reason is that you may have an active infection, but not mount an appropriate IgM or IgG response, because these bacteria are on the surface of the mucosa. And so your typical response is an IgA response in the GI tract, right? Mucosal layer, you get IgA. And so the IgM response may not be very strong, and that's what most of the testing is for. So that's something to kind of consider. And then invasive tests, obviously, when we do endoscopy, we're always taking biopsies now. In the previous institution where I was, we often did a CLO test. That's a rapid test. You take a little biopsy and you put it into this little kind of square thing, and it's test for rapid urease. That's what RUT is rapid urease test. And it's basically the same thing, closed, just a branded version of that. And it will turn pink if there's any presence of organism that's able to, have urease activity. But it's not as high a sensitivity and specificity as biopsy with H&E. And there, though, you're relying on your pathologist really being able to identify these organisms on a Guim stain. And so, I think it all depends on sort of how good your pathologist's eyes are. In some places, they do culture and PCR. I will do cultures and sensitivities for patients who are really failing therapy on the various treatments that they've been tried on. And so in those instances, we will do cultures on patients, but that's not routine. Okay, so what's the treatment? Nowadays, the first line therapy is quadruple therapy. Nobody's doing triple therapy anymore. Please don't prescribe triple therapy to your patients. Why? It's because there's a very high rate of amoxicillin and clarithromycin resistance in most H. pylori isolates, more so clarithromycin resistance. So we've really switched to using quadruple therapy, which is a combination of PPI, bismuth, tetracycline, and some kind of nitramidazole like metronidazole. So one of the things I tell most of my patients about is that you may have some side effects of this. So make sure that you're telling your patients that you may, have some, you may have some nausea from taking the metronidazole, but not to stop the medicine. If you're taking metronidazole, just give them Zofran or something to get through it. And also with tetracycline, not to drink any alcohol, be outside in the, or even with Flagyl, actually, not to drink alcohol, and also not to be out in the sun, because you can get burnt easily. These are all the other potential therapies you could try in patients. I'm not going to go through each and every one, but you're welcome to have these slides so you can have that as your background. And lastly, don't forget that you should do a test of cure. What is that? So let me just go to the next slide here. So that's a test to prove that you've eradicated the bacteria. And you can do that either as the urea breath test or the fecal antigen test. It doesn't matter. Some non-invasive test is usually appropriate. In some instances, we will do endoscopic evaluation for patients who've had resistant organisms that are hard to treat. But often you want to wait about 4 weeks after you've completed antibiotic therapy. And you must make sure that your PPI, again, has been withheld for about two weeks before you do this test. So when you're managing treatment failure, please get a GI involved, just because you really want somebody who's managing this, maybe, need an endoscopic intervention. But the general principles are, don't give the patient the same antibiotics they've previously had, because that bacteria is probably resistant to it. And we typically will give bismuth quad or a levaquin-based treatment for 14 days for most people who've been on clarithromycin previously. And again, if the patient again fails, then you definitely need to refer them to GI. Now, in the instances where severe H. pylori infection leads to peptic ulcer disease, you want to be looking out for those alarm symptoms. Again, in anyone who's over age 55 and has new onset dyspepsia or abdominal pain, any unintentional weight loss, vomiting, blood in their stool, unexplained iron deficiency, or you feel an abdominal mass, progressive dysphagia, and you sometimes may feel that left supraclavicular node called Virchow's node, you want to refer them right away and get them to get an endoscopy quickly. And if your EGD finds a gastric ulcer, our rules are if it's an erosion, you just treat it for 2 months with PPI therapy. It should resolve because it's not beyond lamina propria. But if it's an ulcer, really you have to biopsy the edge to make sure there's no cancer there. So it can be gastric adenocarcinoma, but often it's a malt lymphoma. Okay, and you want to see them back and re-scope them in 8 weeks to make sure that ulcer has completely healed. The reason is that we can't always biopsy a patient when we see them, because if they have a bleeding ulcer, you don't want to anger that area by taking a biopsy. So sometimes you're just doing what you need to manage the bleed. But you want to see them back and make sure that the ulcer healed and it's not like it's not a malignant ulcer. And so that's the main reason why ulcers have to be followed up with a repeat EGD in 8 weeks to show that it's completely healed. And so here's an AGA treatment algorithm for how to manage eosinophilic, how to manage peptic ulcer, dyspepsia and peptic ulcer disease. So overall, you're going to test for H. pylori, and if it's positive or negative, this is how you decide whether to consider an EGD or not. So I'll leave that for you guys. All right, so let's talk about eosinophilic gastritis. So this is a primary eosinophilia, and you have to have excluded secondary causes. What are some of the secondary causes? Maybe we don't see this so much here, but schistosomiasis, and sarcoidosis are actually one of the most common causes for this worldwide. Celiac disease can also present with eosinophils in the stomach. Hypereosinophilic syndrome can, drug hypersensitivity, certain kinds of IBD, and then a few others and graft versus host disease as well. But once you've decided it's probably not one of these things, it might be a primary eosinophilic gastritis, then this is what you need to know about it. So who gets it? There's definitely a male predominance in this disease, so 3 to 1. Although it just went and said no gender or race predilection per se, but that's actually not true. So there is a male predominance. And then usually you see it around the 3rd decade of life. And it's kind of like in the patients who develop EOE, like eosinophilic esophagitis. You often will see it in that roughly the same kind of population. They'll have a history of atopy and eczema and asthma, and they often have other diet-related issues. So these patients will often present with pain, abdominal pain, nausea, vomiting, weight loss, bloating. They can get diarrhea. Again, all of it leads to increased acid secretion. That acid secretion, when it gets into the duodenum and it's not effectively neutralized, will lead to that kind of diarrhea kind of picture. And you see lots of eosinophils, obviously, throughout the GI tract. And it has a very relapsing remitting course. So it can kind of wax and wane over months. People get better on their own sometimes, or they get better with treatment and they feel better for a long time, and then suddenly it can remit. So there's 3 flavors of this based on the Klein classification. There's a mucosa predominant, a muscularis predominant, and the serosal predominant. The bottom line is the serosal predominant is sort of the most severe one and hardest to diagnose, because you have eosinophils that are infiltrating deep into the serosa. So when we do an upper endoscopy, we may see abnormal tissue, but when we do the biopsies, there won't be any eosinophils there, because most of the eosinophilia is really deep in the serosal layer. Unfortunately, what that results in is a lot of inflammation and eosinophilic ascites. So these patients can have ascites that's high in eosinophil counts. So that's one of the presentations. But most commonly, it's either mucosa predominant or muscularis predominant that you'll see. And the mucosal predominant, you'll really just have patients who are saying, every time I eat, I feel really sick to my stomach. I have diarrhea. I really don't know what's going on. And then they get an endoscopy and you'll see this like fold thickening and gastric polyps. and these strange kind of area gastricae that we have shown you here on the right side. And when you take those biopsies, they'll say, okay, more than 50 eosinophils per high power field. The muscularis predominant one can lead to stenosis, particularly in the pylorus, and lead to sort of a gastric outlet obstruction type of picture. And you can see very thickened gastric folds on CT scan. And so these patients are also prone to dysmotility and get kind of a gastroparesis type of picture in some cases. Also difficult to diagnose this because, again, the eosinophilia is in the muscularis layer, which we can't often get to with our biopsies because those only go very superficially. In patients like this, they have peripheral eosinophilia, iron deficiency anemia. You do a special low D-xylose urinary excretion test, which you guys probably wouldn't need to be worrying about. Just send them to GI, we'll take care of that. And the one thing is you do see these Charcot-Leyden crystals in the stool. And these are eosinophils that have formed these crystals. And that's one of the kind of classic finding. All right. Treatment is often food elimination. You can treat with steroids. You sometimes need more immunosuppressive therapies like azathioprine. You do see the use of these like leukotriene inhibitors or mast cell stabilizers, and some biologics have been used for this disease. Minotaurs. Okay, so this is a very kind of test makers' favorite kind of disease to include. I haven't seen much of it. I think I only saw one during my entire time in fellowship and none since then, really. But this is a strange disorder where you have massive overgrowth of the mucus cells and foveolar mucus cells in the stomach, and it leads to these very large gastric folds. And because there's so much mucus production and getting out into the lumen of the stomach, you get a protein losing gastropathy and enteropathy as well, in the sense that you just basically are becoming you're becoming more kind of fluid filled, in that you don't have as much protein. You get protein loss through the stool. And here you also see a lot of hypochlorhydria. The reason this happens is there's excessive TGF alpha production acting on the EGFR receptor, and that makes more of these gastric progenitor cells come towards the surface of the mucus, towards the mucus lineage, and then become more of these mucus-producing glandular cells that secrete mucus and kind of protein waste. In some cases, it's been linked to H. pylori infection and CMV, and so therefore, if you do find those infections in these patients, you're supposed to treat them, and it can actually cure their Minotaurs disease. So that's kind of a good news. So the things you want to do for patients with this, so they'll often present with symptoms of dyspepsia, nausea, emesis. They'll have lots of edema, peripheral edema from the protein losing enteropathy, or gastropathy, I should say, weight loss. So you want to check their labs for hypoalbuminemia. You want to check their stool alpha-1 antitrypsin to see if it's high or not, because that's a sign of stool wastage, protein wastage in the stool, and also for H. pylori. A 24-hour stool for alpha-1 antitrypsin, or you can do a plasma alpha-1 antitrypsin clearance. Those are slightly more sensitive tests. And again, you can send them to GI. We can order those, or we can do EGD with biopsies. Most common treatments, we do use H2 receptor agonists and anticholinergics or octreotide. And if they have H. pylori, we will treat that. When it's completely unrelenting protein loss, sometimes these patients will need a total or subtotal gastrectomy, which is pretty significant. All right. In terms of gastric emergencies, the most common one, I think the one we probably get paged about the most on our inpatient service, is going to be life-threatening GI bleeding. The most common causes of those GI bleeds are peptic ulcers, gastric varices, Delafoy's, or AVMs. But there are others, obviously. And that's just in the stomach. Okay, so there's other things that can bleed in other parts. The management of unstable GI bleed, I think most of you probably at this time of year already know all this, but one thing I do see a lot of primary teams not doing is testing for H. pylori. And so one of the things I hope you take away from this talk, if nothing else, is it should be a reflex reaction. If you're thinking someone's coming in with a GI bleed and it's upper GI bleed, and you're even suspecting peptic ulcer disease, you put that in your differential, then you must test for H. pylori, because if you're thinking it's from peptic ulcer, the most common cause is H. pylori, and if you haven't tested for that, then it really, it really behoves us to not do that. Now, a lot of times people don't do it because they're thinking, oh, GI is going to get involved and they're going to do a biopsy. That's fine. But sometimes that doesn't happen. In other words, oh, we come and we say, oh, they can be done as an outpatient or something, and falls through the cracks. And then, the patient never followed up, and they had it all along. Nobody tested it, and they never got treated, and they show up with gastric cancer later. So we don't want that to happen. So what we were taught as fellows, as residents, when I trained, was no matter what, it's, you should test for it, whether you do, depending on the timing of whether they can do the stool test. If they're producing a stool, do that. Otherwise, at a minimum, check their antibody levels, an IgM or an IgG or both, just so you know roughly what their status is. And then if you see that there might be a hint that there's some H. pylori involvement, then at least get them the appropriate follow-up so somebody can do a biopsy as an outpatient, or they can do a stool antigen or whatever. But in the case of the unstable GI bleed, large bore IVs, IV PPI. If you have cirrhosis, then make sure you get them ceftriaxone, large bore IVs, and hemodynamic management. Intubation if they're having hematemesis, and obviously let GI know. I think you guys know all of that. Gastric Falvulus is actually a very common gastric emergency in populations. We see a lot of this in populations where you have patients and residents in homes, and patients with Parkinson's disease and stuff like that. So people who have a lot of stasis, they're just not moving a lot. This is most commonly actually seen in the pediatric population, but in the adult population, we often see it in the kind of residential population. It does peak, however, in adults in their 50s. But again, like I said, where I've seen the most of these cases, and I've had a couple of these cases during my residency fellowship that showed up mostly from residence homes. So the most common sign and symptom is this Bouchard's triad, where you have sudden onset of chest pain or upper abdominal pain that is preceded by just basically unproductive retching. So you'll be retching but not bringing up anything. And then when they come into the ER, somebody will be trying to pass an NG tube and always like hitting something, they can't get it through. That's when you need to just stop and go get an X-ray on this patient. And you can see that there's actually these, there's air basically in the what should be the mediastinal area. And that's actually a stomach that's like rotated on itself. And you see that gastric viscus that's filled with air in the chest. A CT scan should then be done just to kind of confirm exactly what the rotation of that stomach might be, and that does allow us to go in there with an EGD and detorse the person. Some people do recommend that they should be decompressed by an NG tube. I really don't think that's ideal. We should, GI should probably be involved. So if you hesitate to do that, that's probably right. Wait for us to come in and detorse them. It's a lot easier to do it when you have endoscopic visualization of what you're trying to detorse than to do it blindly. All right, and then some of these patients will need to go to surgery very commonly, and there's up to 30% mortality. So it's easy to miss this because a lot of times people come in and they're saying chest pain and and really they're getting worked up for cardiac and pulmonary things, and people miss this very often. So always think this could also be a potential gastric volvulus in those instances. All right, I'm really flying through here. Sorry, guys, it's already 12:48. Okay, so other gastric emergencies, you often hear about ingestions, whether people, we recently had a very young guy who was, he was a bartender, and he had just gotten some new beer, and I think maybe some of you might have heard about this. He had just gotten a new keg of beer, and he was going to test it, and he opened it and drank it, but apparently there was some alkali material that was used to kind of create a stop in the stopper so that it doesn't pour out or something like that. And it was like severely alkaline material, and he swallowed the whole thing. It was like a 20-something-year-old guy, and came in with a horrible ingestion. And this is a very much gastric emergency. You have to page us and thoracics, and often we have to go in and see how severe the injury is right away. So you're supposed to scope these patients within like 8 hours to see exactly what the degree of injury is, whether it's transmural or superficial. And if it's leading to any kind of mediastinitis or peritonitis, then usually we have to have our thoracics team involved. It can lead to coagulative necrosis. often affecting the gastric antrum the most. So these patients can get very sick and be in the ICU and very high rate of mortality as well. So it's very important to stay on top of it. So again, what you're supposed to do is call, obviously, GI surgery, but also let your regional toxicology poison control know about these patients, manage their airway, manage their airway, make sure you get the appropriate chest and abdominal x-rays, and then the EGD. It says here within 24 hours, we really try to do it within 8. Do not place an NG tube in these patients, please. And don't try to do anything to induce emesis in any ways. If they are very nauseous, you want to keep their nausea under control as much as you can to reduce the retching and vomiting that will potentially lead to perforation. You can use some neutralizing agents, and sometimes we've used steroids or systemic antibiotics in these patients. Often they need to go to surgery soon, though. Other things like foreign body ingestions. Now, typically, this is most common in children, although we see so many patients with psychiatric illness, with developmental delays, people from prison populations, because it's a way that they can get out of prison, and at least for a brief period of time, or people with alcohol intoxication. People come in with all kinds of things. I pulled out 3 Sharpies from stomachs. I think the hardest things to pull out are button batteries and things like this, which is a safety pin. So anything sharp and pointy is the thing that's going to cause the highest rate of perforation, which kind of makes sense. But if it's longer than 5 centimeters and rounder than 2 centimeters, then really it can be removed. The only thing is that if you have a disc battery, like an alkaline battery, you need emergent endoscopy with intubation. And again, if you have any kind of drug mules that come in having had recent narcotic packets or anything like that, that should not be retrieved endoscopically. Those have to be done surgically. And we've I've had a couple of those in these instances. All right, so now we can move on to the small bowel. Most common is malabsorption and celiac disease. I don't know if we're going to be able to get through all of this, but I'm going to go through it quickly. Most common things you're going to see is people presenting with chronic diarrhea, right? Like, I've been having diarrhea every time I eat this or that. My stomach's upset and I'm having diarrhea. And so this is a common problem I deal with in the clinic. So most of the time it's because people aren't hydrolyzing their starches properly, and then it can't get absorbed by cellular transport, because only monosaccharides can be actually transported across the luminal membrane. So when you have impaired hydrolysis, that leads to a lot of disaccharides that are just being left behind and not getting broken up. And then, you have different bacteria sometimes that break those down, and they release hydrogen sulfide, which creates a lot of bloating and gas. And also, when these are not broken down, they end up in the colon, and the colon does not like any kind of disaccharides, and it'll create an osmotic diarrhea where it'll just like throw a bunch of liquid at it to get it out. And so for these patients, it's really, these are the FODMAPs, right? And so you want to put them on a low FODMAP diet or send them to GI. Often they present with abdominal pain, bloating, postprandial diarrhea. You can test their stool gap to see if it's more like an osmotic diarrhea. Usually it's like stool gap of over 150 or over 100 will be more diagnostic, and they'll have a low stool pH. They'll be very acidic. All right, and often these patients are treated with either avoidance of those foods, like if it's lactose that's the problem, then they got to avoid lactose, or taking some kind of enzyme replacement, or really just avoid those other foods. All right, and I'm going to skip this and talk about celiac disease. So celiac disease is a common disease of the small intestine where you have gluten that is taken up and deamidated, taken up by macrophages, and then presented sort of as an autoantigen to T cells. And those T cells basically come back and form antibodies that can destroy your local enterocytes. And over time, as those enterocytes are destroyed, you lose your nice, beautiful villus brush border, and you lose your absorptive surface in the small intestine. All right, so duodenal biopsy specimens. This is when you have untreated celiac disease. So, here you see like basically the blunting of these villi as opposed to what they should be looking like on the right when they're normal. Most common symptoms are diarrhea, obviously bloating, steatorrhea, in some cases abdominal pain. But if it's asymptomatic, they might only present with iron deficiency anemia and a mildly elevated ALT. So anytime I evaluate patients for abnormal liver enzymes and I just see a mildly elevated ALT, even if they're not endorsing any abdominal pain, bloating, or diarrhea, but I see that they have an iron deficiency anemia, I always test these patients for celiac by serologies. Now, in about 15% of patients, the serology may be negative, but they may actually have true celiac disease. So they really should be followed up, especially if they have that iron deficiency anemia and elevated ALT, or even just iron deficiency anemia alone and a negative TTG. You should still do an upper endoscopy to rule out celiac disease. And there are some cutaneous versions of this disease, like dermatitis or herpetiformis, some follicular dermatitis, and these are all the other kind of GI and the non-GI manifestations of the disease. Osteoporosis is very common in these patients, so because of the lack of appropriate absorption. And it's very commonly seen in patients who have Down syndrome and type 1 diabetes and IBD, because presumably when you have one type of autoimmune disease, you can develop other ones. So you always want to think about that in these patients. So TTG, IgA is the most sensitive, endomysial is next, and antigliadin is the last. So always check for TTG, IgA. For a patient who has low IgA levels, so you always check a total IgA every time with your TTG, IgA to see if the patient has low IgA levels to begin with. Because if they do, then you need to go back and order TTG, IgG, okay, to see if they might have celiac based on a high TTG, IgG. And that's what I tend to do. Obviously, the gold standard is still doing duodenal biopsies for villus blunting. And if all the testing comes back negative and you're still not sure if this person has celiac, just do the genetic testing, because that'll tell you if they don't have at least 2 of the genes for celiac, there's no way they can be celiac, right? So that's often what I do to kind of decide that. And for patients who are not celiac but are gluten sensitive, they might still benefit from a gluten-free diet. So that's another reason to kind of go through that pathway and figure out if they have it or not. Obviously, the treatment for celiac is gluten-free diet, and you do need to monitor the TTG if they have elevated levels to begin with, every about 8 weeks to 6 months at least, to see if that they're remaining gluten-free. The most common small bowel emergencies you need to know of are acute mesenteric ischemia. This is when there's up to 75% reduction of mesenteric blood flow. And there's inappropriate oxygen consumption for over 12 hours. So this is sort of a disease where you basically have hypoxic injury to the bowels, and the most common is either SMA thrombosis or SMA embolus, and it can be acute or chronic. For patients who are over 50 years, you should have a very high index of suspicion, particularly if they have a cardiac history, recent MI, recent hypotension, arrhythmia. In younger people who are on some of these meds that I mentioned, like phenylephrine, amphetamines, cocaine, you also want to think about that. And again, your abdominal pain is exceeding what you see on physical findings, right? So that's sort of the classic clinical symptom. That's early though. Later on though, you might see more just like abdominal distension, a lot of bloody bowel movements because the tissue is already necrotic. So you see elevated white count, elevated lactate. You want to do a CTA. That's the test of choice, not a regular CT. And that way they can also do an endovascular therapy if it's indicated in that situation. All right, SBOs, these are mechanical blockages, basically, where the small bowel twists on itself. Different from an ileus where the bowels just aren't moving, they're not peristalsing. This can be, an SBO can be partial or complete. It can be simple or strangulated. The most concerning ones are the closed loop obstructions where both sides are twisted off, and that's going to be a surgical decompression, can't be done endoscopically. Most common causes are inflammation, adhesions, cancer, foreign body, and intussusception. So most common symptoms are nausea, vomiting, obstipation, abdominal pain, and distension. You need a CT with PO contrast to really see whether it's a closed loop or strangulated or not. And if it is, you need to go to surgery. Otherwise, if it's just partial, you can manage that medically with NG tube fluids. If it's intussusception, that we can endoscopically decompress and without a problem. But if it's an ileus, you just want to limit the narcotics, put an NG tube fluids, and get them to move.